So, hello friends. So, today I'll be talking on this topic hiccups. So, although this may appear very simple, so we had a very interesting case in our ICU, which was fairly refractive to all the conventional therapy we give. So, we pondered about trying to understand whether it is as simple as we think it is. So, so this is although a condition which we tend to see often in ICU. Sometimes this can be refractory, so we dwelled upon to understand the whole science of the hiccups. So wish to acknowledge my colleague, Dr. Surya, who helped me develop this content. So I'll just take you through the case, which was a challenging case for us, who had refractory hiccups for more than 3 weeks, to be precise, before we could really break his seizure, because this was really troubling him. So this was a case, 42-year-old gentleman who is from a very, very affluent family and more of a VIP sort of a guy from a very political background. So this gentleman has had a history of seizure disorder, and unfortunately, he was alcohol dependent as well. And most of his seizure possibly would be related to his alcohol. In addition to this, he had a prothrombotic state. So where he had two events of venous thrombosis. So he had cortical venous thrombosis 9 years back, and he was meant to be on anticoagulants, and he was not necessarily very compliant with these anticoagulants. And 5 years back, he had a mesenteric vein thrombosis. So again, there were two big warnings in his life with a cortical venous thrombosis and mesenteric venous thrombosis. And he was meant to be taking anticoagulants, and he was essentially not very compliant with regards to regularity of his medications. So just to put this picture into perspective, so the mesenteric vein, when we say splanchnic vein thrombosis, so it constitutes all these three veins. So it has superior mesenteric vein, inferior mesenteric vein, and the splenic vein. And these are very vital in the supply of all your intestines and small bowels. So he came basically to our ICU with acute abdomen and with a seizure. So this was a very complex situation he came with. So seizure got settled, but what was really complicating was his again he had developed recurrent splanchnic venous thrombosis. So CECT, contrast enhanced CT abdomen, showed he had a splanchnic vein thrombosis, and the whole of the small bowel looked very dusky. And because it was a venous, it's not mesenteric artery thrombosis, it was more of mesenteric vein thrombosis. So it was more of venous ischemia of the small bowel. So the whole consensus at that point of time was, since it's a diffuse sort of a bowel ischemia due to venous, there won't be clear demarcation of the bowel. So surgical intervention was kept as a last option. So he was obviously put on anticoagulation and antibiotics, and we were waiting on him to see if the venous flow gets resumed and his bowels get functional again and he gets normalized. So he was put on antibiotics and anticoagulants. So fever continued. He continued to have persistent fever spike. And over we waited for around close to around 10 days to 12 days, but fever was not abating, and the repeat CT done showed a very evident of bowel ischemia, so he had to undergo surgery. So he did undergo surgery, and at that point of time, we were really worried whether any of the whole bowel would it be salvageable or not. So essentially, around three-fourths of the small bowel was removed, and around 150 centimeters was what they could salvage. So he had a stoma put in, and so everything. So I just rushed through this because the whole thing about this presentation is about to talk on hiccups. So what happened after the surgery also, we sent him to ward, he got better. So he had two intubations in ICU, and it was a very stormy course, although when I'm narrating, it all appears very simple. It was a very stormy course, but he tided over that. And post surgery, we thought he may not survive, but he really did well. He recuperated. We extubated him. Then we sent him to ward actually. So in ward, he continued to have this fever spike, 3 to 4 spikes he used to have every day. And this is day 7 post-op. So we are looking at third week. So he had again a CT done, and CT showed large collections in the abdomen. So percutaneous intervention was done, and this abdominal collections was removed by putting two drains on both sides with the stoma in place. So after that, he nicely improved, and we sent him home with the drains and with the stoma, because the drains surgical team also felt that it's good to leave the drains in because there was murky fluid that was coming out. And he was put on TPN, and later on slowly we initiated feeds as well. And nicely the stoma started working and he got better. So at the time when we sent him home, it was close to around 4 weeks. And he went home, and we were all happy that he really got a second life because he had a very turbulent course, and he became afebrile completely and he was sent home. So after he went discharged home on stoma and bilateral drains, and then the new problem that started in day 7 post discharge, he started developing hiccups at home. So, and these hiccups, even when he was in the ward, he used to have some hiccups. So he was put on metoclopramide, and as one would use in this situation, and he was on PPIs for his whatever issues he's had. And then, so he started developing the hiccups. So we put him on baclofen and chlorpromazine. So these are traditionally one would be using it for these hiccups. So he was on metoclopramide, he was on baclofen, and we put him on chlorpromazine. Since this was a VIP family, they were in touch with me regularly, and we used to guide them about the dosing of these drugs. So the clinical examination at that point of time when he came for review, it all appeared very good. Stoma was working. He was moving bowels. He was completely afebrile. So the whole clinical examination looked very promising, and he remained afebrile, which was very comforting for us. But the key thing that was troubling him was the hiccups, and the hiccups was almost continuous for him. And at that point of time, on his OPD visits, we did investigations. Sodium was low. So we corrected the sodium, and he had a brief stint of admission again to correct all this. We did a cortisol level in the light of low sodium and high potassium. All that was normal. So, and we cranked up these medications. We went up to maximum dose of baclofen. We went up to maximum dose of chlorpromazine. He was on metoclopramide 10 mg TID, and chlorpromazine he was on 25 mg TID. Baclofen we went up to 30 mg, and maximum was 45 mg that one could give. So we had literally maxed out on all the drugs for hiccups. So he was on PPIs, he was on metoclopramide, he was on chlorpromazine, he was on baclofen, and he was on some syrups also. We had put him on lignocaine syrup. So that's when we started digging into literature, because we were really pushed to the wall because the seizures would just not abate. And seizures were quite disturbing, and we could see him that he was really troubled when he had these seizures, and it used to be really limiting his routine sort of a day-to-day recovery to wellness. So, and this was very troubling. And we were looking into literature, and we were only thinking that maybe the next thing is whether we should resort to some sort of vagus nerve or phrenic nerve um, ablation with regional anesthesia. So we were looking at that aspect. That's when we sort of dwelled into literature, and there was a whole sea of literature. Although this literature is all very old literature, but it is worthwhile for every intensivist to have conceptual understanding as to how we approach these refractory hiccups. So hiccups is also called single tusk, and the actual meaning of single tusk is caught in act of sobbing. So that is the sort of literal translation of single tusk. So why does hiccups happen? So hiccups is due to involuntary and repetitive contraction of the diaphragm, and sometimes with intercostal muscles also. The key problem lies with the diaphragm, because there is involuntary and repetitive contractions of the diaphragm, and it can be due to intercostal muscles. And what happens is an individual takes a very rapid intake of the air, and there is a sudden closure of the glottis that happens, and this produces that sound. Tick, tick sound uh, emanates from the sudden closure of the glottis without complete entry of the air inside. So there is a sort of interruption to the entry of the air when there is a sudden glottis closure, which leads to that sound. Hic. And all this is involuntary. And and when you look at hiccups, it is categorized into acute hiccups which last for only less than 48 hours, after any sort of a physiologically or pathologically. Then there is something called persistent hiccups where it lasts for more than 2 days. Then there is something called refractory hiccups, which this gentleman had, where it lasts for more than 1 month. Because his hiccups, cumulatively, when we looked at it, it had reached third week, and we were really pushed to the wall of maxing up all his medications. And I used to get messages at any point of the day saying that hiccups is not abating when he was at home. And one admission he had in between for only this hiccup because he got really frightened and he wanted to be in a hospital. So it was troubling him to that extent. So intractable is more than 1 month. And we had even put a timeline that if hiccups does not abate in 1 month, we should think of Baker's or a phrenic nerve ablation through regional anesthesia. So that we were really thinking on those lines. And that's when something happened. So how we sort of fix these hiccups is what we want to highlight here. So when you look pathophysiologically, it is quite complex for all of the intensivists who would have forgotten. So the whole anatomy of the vagus nerve and the phrenic nerve. So if you see on the left side, so this is the vagus nerve. So if you see the type of vagus nerve innervation, it literally innervates every organ. It innervates, it has relation to all the thoracic structures and it innervates most of these abdominal organs. So it is a very complex nerve. And then you have this phrenic nerve you see on the right. So this is the phrenic nerve, and the phrenic nerve, as you see, it predominantly innervates your diaphragm. So the main pathophysiology of hiccup lies in the local, but predominantly driven by your reflex arc. And reflex arc consists of three elements. So the three elements are you have this vagus afferent. So this is the vagus afferent. For all the internal medicine guys, you would all be very excited that you would have learned all this during your medicine. So for any reflex action, you need to have this activation of these afferent, and then you have this efferent, which is by the phrenic nerve. Then you have the central component, which is by tractus solitarius and dorsal nucleus. So this is the reflex arc, which tends to be activated in the whole sort of a hiccup mechanism. So there is a vagus afferent, phrenic efferent, tractus solitarius, and dorsal nucleus in the brain stem, which tends to get activated, and all this activation is mediated by this GABA. So GABA mediates this whole activation, and they get hyperactivated, and the hiccups happen. So any drug that we use for hiccups control should have some mechanism of action on these structures because you have to break the activation of this reflex arc, which gets activated. And the closure, the reflex closure of the glottis that happens due to the sudden rapid intake of the air and the reflex closure of the glottis is mediated by this vagus afferent. So this is the pathophysiological understanding. So figuratively, I think if you remember this sort of a picture where you have a vagus afferent, phrenic efferent, and this nucleus, these are the key elements which are quintessential in the activation of this whole hiccups. So when you look at the etiology of hiccups, so I'm sure this may not be asked as a question in intensive care, but it is good to categorize into four structural sort of a problems: neurological, GI, thoracic, and ENT. But in this gentleman, he literally had pause in everything. So neurologically, any structural problem in the brain, so be it trauma to the brain or neuroinfection, neoplasm, or any infarct, meningoencephalitis, or seizure. So our gentleman had this seizure. So you could say that is also one trigger for his ongoing hiccups. So we don't know. But predominantly, we would assume it all happened after the surgery. So we assume it is all the GI which was triggering his hiccups. So when it comes to GI, it can be anything and everything in the GI tract. So anything in the esophagus, esophageal cancer or tumor or esophagitis. And gastroesophageal reflux is the most commonest, or peptic ulcer disease, or any tumors in the abdomen, cholecystitis, pancreatitis, any inflammatory process within the abdomen. And hiatus hernia is another problem. You can easily, intuitively understand that hiatus hernia has a bearing on the diaphragm, so you would have hiccups. So any pathology in the abdomen, even the intra-abdominal collection, abscess. So our gentleman had all these problems. So he had huge intra-abdominal pathology. He had intra-abdominal collection. He had drains put in. So all this may be triggering the hiccup. So he had a neurological cause, which is seizures. He had a GI cause and thoracic. So any pericarditis, MI, pneumonia, asthma, or any tumors, mediastinal tumors, all this can cause hiccups. ENT, it can be laryngitis, pharyngitis, or otitis. So just easy to remember if you categorize into these causes. But in addition to this, there are metabolic also. So our gentleman had hyponatremia. We thought hyponatremia may have triggered the hiccups. So we treated hyponatremia, but still his hiccups did not settle. So hyponatremia, hypokalemia, hypocalcemia, or AKI, and alcohol. Our guy had alcohol issue, even that is known to cause hiccups. So anything and everything under the sun can cause hiccups. So, but these are some of the defined reference causes. So our guy had alcohol, hyponatremia, abdominal cause, and seizure. And what about the drugs? So our patient was on the antibiotics. I mean, what sort of a cause would that be? Any patient in ICU would be on antibiotics. So antibiotics is listed as one of the cause for hiccups. Benzodiazepine opioids. Our gentleman was on opioids and benzodiazepine. He was on psychiatric medication as well. Glucocorticoids can trigger seizures, chemotherapy, and dopamine agonists. So there are whole lot of agents. So if you look at this, anything in ICU, any patient in ICU should have hiccups because all these agents are something any ICU would be on. And post-surgical, so any surgical procedures or even any pharyngeal manipulation like intubation. So all these our patient had surgical procedure he had, intubation he had, and psychological. So our patient had huge psychological and behavioral issue. He was ethanol alcoholic and he was on a psychiatry review. So and he had a lot of fear factor and so stress, fear, anxiety, all these are causes. So this is summarily how you can categorize the cause of hiccups. So anything and everything can be a trigger for hiccups is what you can sort of reconcile to when you hear to this. So that's about the causes of seizures, and we spoke about pathophysiology. So how do we now approach this hiccup? So there are certain physical maneuvers to terminate hiccups, which physiologically hiccups happen to any of us. We use all these physiological maneuvers. So we tried doing this in addition to all the pharmacological medications. So Valsalva, I used to tell him to do Valsalva maneuver every 2 hourly or 3 hourly, and we had a physiotherapy helping him to do Valsalva, but that helped only temporarily, but his hiccups used to be continue after that. So taking a deep breath in and blowing with the resistance is what Valsalva, or holding the breath for 5 to 10 seconds and gargling very cold water and biting on the lemon or sugar. So these are some of the reference maneuvers that has been indicated, and pulling the tongue out is also indicated in up to date as one of the maneuvers, and pulling the legs to the chest and bending forward is also shown to help. These are all the ways possibly physiologically it helps, but pathologically whether this will really help, we do not know. But we did encourage him to do some of these things, and putting even pressure on the eyeballs has been proposed. So, but the simplest one that we tend to practice is the Valsalva maneuver. So all these is something that you can just keep in back of your mind. Maybe this maneuver, pulling the legs to the chest and bending forward, may have some sort of a hypothetical benefit with regards to physiological standpoint. So all other things you can all try if it is physiological. So we'll move into pharmacological therapy. So what are all the agents that are available and how do they act? So we look at metoclopramide, which many of you would be very familiar with, and just to revisit as to how they act. So they act on dopamine receptor. So it's a D3 dopamine receptor antagonist, and metoclopramide also acts on the 5-HT receptors. Uh, and it also helps in local. So it has more central effect and it has a peripheral effect where it enhances the gastric emptying. So by doing this multimodal effect of dopamine antagonist and 5-hydrox and serotonin receptor and increasing 5-HT in the brain, and by facilitating gastric emptying, it has a multimodal effect in trying to abate the hiccups. So any pharmacological drug that I'll be talking will be mediated through three. One is dopamine, and one is 5-HT, and one is to GABA. So GABA mediated neurotransmission inhibition. So the side effects of metoclopramide is it can cause tardive dyskinesia. So we were using 10 mg 3 times a day for our gentleman, and that did not really do much at all to him. So domperidone, which is again an antiemetic, is similar to metoclopramide, but the key thing is it does not cause tardive dyskinesia because it does not cross blood-brain barrier. But the problem with domperidone is it can cause QT prolongation at a dose more than 30 milligram per day. It can cause QT prolongation. So we use metoclopramide for our gentlemen. It did not help. Then baclofen is something that most of you at least would have tried using in hiccups, and this is a proposed drug or a recommended drug. So how does baclofen act? So baclofen acts on, there are GABA alpha receptor, beta receptor, and gamma receptor. So basically what it does is it acts on GABA B agonist. So GABA receptors lead to inhibitory neurotransmission. Basically, it sends inhibitory signals to curtail the activity of these nerves and facilitates relaxation. So what literally happens in hiccups is, so there is this vagus efferent which gets activated. So there is the activation of the vagus nerve or the phrenic nerve which innervates the diaphragm. So there is activation of this which does not allow relaxation of the diaphragm. So there is no relaxation of the diaphragm because of superactivation or hyperactivation of vagus efferent and the phrenic nerve. So we need to relax these diaphragm muscles and we need to relax the lower esophageal sphincter. So inhibitory neurotransmission happens by GABA activation. So GABA B receptors, B receptor activation leads to inhibitory neurotransmission. As you see, minus is inhibitory neurotransmission causes relaxation of this diaphragm and it pulls down or underwhelms this activation of this vagus efferent or phrenic efferent. So that's the mechanism in which these agents act. But the problem with baclofen, too much of baclofen, we have seen in ICU, especially elderly with acute kidney injury, it can cause ataxia, confusion, and drowsiness. So maximum dosage recommended is 45 milligrams. So in our patient, we had given 10 mg TID, and we had even asked him to take another additional 10 mg if things were getting refractory. So it did not really help him, and his seizure really did not change with addition of baclofen as well. So now we'll move to gabapentin. So as you see, if you're looking at the list of drugs, we are moving from metoclopramide to chlorpromazine to baclofen to anti-seizure medication sort of a thing because gabapentin is more of neurology drug. So how does this gabapentin act? So gabapentin, as the name sounds, it again increases your GABA, but not by direct action on the GABA receptor. It inhibits the calcium gated, voltage gated calcium channels and causes activation of these GABA receptors. And this prevents the production of excitatory neurotransmitters and facilitates inhibitory neurotransmission. Your whole GABA is to cool down and cause more inhibitory neurotransmission and prevent the secretion of excitatory neurotransmitters. So that's the whole function. So gabapentin tends to act indirectly by inhibiting these voltage-gated calcium channels, and it inhibits the production of excitatory neurotransmitters and mediates inhibitory neurotransmission. So that's the way it acts. And so chlorpromazine. So we use chlorpromazine very popularly. Largactil is the thing that you would be using. So we use chlorpromazine that also acts as a dopamine antagonist. It's an antagonist of dopamine, H1 receptor, and the muscarinic receptor. So basically, it is an antagonist of this. It is very little similar to metoclopramide, which is a dopamine antagonist, but it also has an effect on H1 and M1 receptors, muscarinic receptors. So we use chlorpromazine for our patient. We use baclofen for our patient. Then we use metoclopramide. We used proton pump inhibitors with local application. And we used all those maneuvers. And even CPAP, positive pressure ventilation, also is recommended as a means to abort the hiccups. We used that also. We used a little BiPAP machine, but it would settle, but after that it would recur. So, and he was not compliant with that BiPAP machine. So these are some of the maneuvers and these are the pharmacological drugs that are available. But how do we now manage? We had put him on all these and we were really pushed to the wall because other maneuvers you should think of is phrenic nerve or vagus efferent ablation. So now let's look into studies because after having reviewed all these, these are the class characteristic or recommended drugs that you have in your armamentarium, but nothing has helped. The only thing we had not used was gabapentin. And what really did the magic was we just added in a gabapentin, and remarkably, the hiccup stopped. Like it's just like a miracle, it just stopped. We just added gabapentin at 900 mg per day, 300 mg three times a day, in addition to all this, and it just got aborted. So that's when we looked into literature whether is it something normally that we have done is something which is a norm, or is it something very different that we did to stop the hiccups. So when then we dwelled into the literature, but one disclaimer is all the studies are in 1990s, 1980s, and 1970s. So there are no major recent studies. We looked into metoclopramide studies. So this was a study by Wang et al. From Chinese. It's a double-blind randomized controlled trial. So as you see, most studies here I'll be talking are all case series and small studies like 36 patients where they use 10 mg TID of metoclopramide versus placebo for 15 days, and they found that the efficacy of hiccup resolution was 11 out of 17 as compared to 4 out of 17. But there is no rocket science. We use this, it didn't help our patient. Then there is this Indian study, which is again a case series where they use 10 mg TID and all these patients had improved. These are all with hiccups. Then we'll move to baclofen studies. So this is a Zhang et al. Again, a small study, double-blind randomized controlled trial, 30 patients, 10 mg TID for 5 days in placebo. As you see, the response was very good. 14 out of 15 complete resolution of hiccups as compared to 2. But we use baclofen. So we had used metoclopramide. These studies are only with one agent. So we use baclofen, we use metoclopramide, but our hiccups had not resolved. Then there is this other study by Ramirez et al., double-blind randomized. As you see, it's a very extremely small study. 8 patients, 5 mg TID for 3 days, and followed by 10 mg TID for 3 days versus placebo. And here they had complete resolution of hiccup. But in our patient, as I said, we used 10 mg TID of baclofen. It did not do anything. And Guland et al., this is a study by French case series. They used for 34 patients. They used baclofen up to 75 milligram per day. And as you see, complete resolution of hiccups happened in 18 out of 34 patients. PR is partial resolution happened in 10 out of 34. And treatment failure did happen in their series in 6 out of 34. Maybe our patient also will come in this category. Despite baclofen and metoclopramide, there was a treatment failure. So this was a German study, case series in 29, where they use combination. And this is what we tend to use. We use baclofen, then we used, instead of cisapride, we use metoclopramide, then omeprazole, 20 mg per day. And complete resolution happened in 11 out of 29, partial resolution in 2 to 29. If in this case series, if patients were refractory to this, then they use gabapentin. So where they use 1200 milligram plus metoclopramide plus omeprazole. Even so, here the point to note is even though they added gabapentin in 10 patients, where the complete resolution only happened in one, and partial resolution happened in 2 out of 10, which means that 8 of them still did not respond. So, which goes on to show that gabapentin is not like a magic drug. But in our patient, when we added gabapentin to metoclopramide with baclofen with PPI, then it completely got stopped. And even today, as I'm giving this, I'm recording this talk, this patient had come to our OPD for a follow-up, and his hiccups had not recurred, and we are weaning all the drugs slowly. And we are weaned off gabapentin, is only on baclofen SOS at this point of time. So, which means to say, it is quite patient-centric, patient-specific. We do not know which drug does the magic. So that is how it is. So this was another gabapentin study by Italy, case series 43. They used 9. Here, if you see, 85% showed complete resolution and 15% showed partial resolution, and treatment failure was there in 2 out of 2 patients out of 41. So this is another Italian study with gabapentin, eight patients, 1200 mg per day, complete resolution. So there are these case series which showed us the sort of a path that gabapentin possibly has a better efficacy when things are getting refractory to other conventional drugs. So these are the studies for gabapentin. So you have 2 Italian studies, and then you have one German study which showed that gabapentin possibly became more beneficial. Then there was this Thompson et al. Again case series. If you see with gabapentin, there was complete resolution in 17 out of 17 patients. So all in all, if you see, the studies with gabapentin seems to be very provocative and compelling that efficacy rates seemingly appeared much better. Then let's look into chlorpromazine because we had used chlorpromazine for our patients. So this is a study by Friedgood et al. Case series 50. And even if you see with chlorpromazine, the response rate was very good. 82% was the response rate. This was a French case series. If you see, the complete resolution happened in 40 out of 50. And our patient was on chlorpromazine from day one. but we did not get this type of response what we are seeing. And other agents that have been used for hiccups is Jacobson et al. They use sodium valproate. As I said, they are moving from metoclopramide, chlorpromazine, and these drugs to more of anti-epileptic drugs to abort the hiccups. So we went for metoclopramide, chlorpromazine, then to gabapentin, from baclofen to gabapentin, now to sodium valproate. So they've used this, and 80% was the response rate. And this was a case series where they used carbamazepine, again anti-epileptic. So where the response rate was very poor, as you see, 1 out of 4 only responded. So the only thing we are trying to sensitize is there are multiple drugs in armamentarium, but if it gets refractory, you just have to pick and keep trying different combination is what we could make out. And most of these studies, as you see, there are very small studies limited to case series. So there's no robust sort of a science to say this drug, any drug would do a real magic. So one has to try different combination. But if it gets refractory, possibly we have to move in to add some sort of an anti-epileptic drug. And what did magic in our patient was gabapentin. So the other non-pharmacological things that have been tried. So we were really looking hypnosis anyway. We do not know how much it would have helped in our patient was had a behavioral issue. So this nerve block is what we were really thinking. Phrenic or vagal nerve block if things were not abating with any of these drugs. But luckily for us, gabapentin did the trick. And implantation of vagal nerve stimulator or similar neuromodulation. All this becomes a little more logistically challenging and we do not know. But definitely regional anesthesia with nerve blocks possibly would have helped him to abort the hiccups as a next step is what we would have thought. So now summing up, so I've spoken about baclofen, chlorpromazine, metoclopramide, gabapentin. So how do we approach next time we get some refractory hiccups, even for all our intensive care listeners? So maybe the way to go up is to draw up your own protocol. So the recommended is baclofen, which we started. Maybe see upfront, the recommendation is gabapentin is something that is considered as a first line. These are the first line drugs. So we had put him on baclofen. Maybe our pick was wrong. We should have possibly picked up gabapentin. So this is the first line. You have to think of any one of these drugs. If these fail, then you move to the second line, which is metoclopramide, which our patient was on. These are the sort of level of evidence. So you see, the evidence for gabapentin also is level 4, which is not the greatest of the evidence. So we had put on the best sort of available evidence. We had put on baclofen, we put on metoclopramide, but really what remarkably stopped is when we added gabapentin. So this is the second line. If second line fails, then you need to go to third line, which is chlorpromazine. And we had put him on chlorpromazine. We had put him on chlorpromazine 25 mg 3 times a day from day, very early on when the hiccup started. And this is put his third line. So other choices is all the anti-epileptics like carbamazepine, valproate, phenytoin, ifedipine. So this is the way we could approach. So after we had this challenging case, we have drawn up our own ICU protocol. So keep gabapentin in back of your mind, and but you have to try out different combinations and see what best works for your patient. So, and this really was an interesting case. So we'll write a letter to editor to some journal to just indicate that a simple thing like hiccups can be quite challenging and can be quite disturbing to some of the patients. And we need to have some clarity on the type of drugs that are available that we can use in different combinations, in different doses to abort the seizures. So thank you one and all. So you can visit my website www.drpadipangappa.com to rehear to this lecture. So thank you one and all.